Hello everyone. In today's video, we want to look at liver function tests. We want to see what are the liver function tests, what are their significances, and how do we apply them in different medical conditions. So we shall look also on interpretation. How can we interpret the lab results of liver function tests? And the liver function tests we have majorly, it is a panel, and these liver function tests include, they are categorized majorly into three. Those that test the integrity, what we call cellular integrity, and those that test hepatocellular integrity include majorly ALT, then we have AST and LDH. So these three, they test what we call hepatocellular integrity. So whenever there is any damage of the hepatocytes, we are going to see them being elevated. And as I begin, I normally tell you that these liver function tests, or the enzymes, specifically these are liver enzymes. And at LDH5, we shall be looking at enzyme LDH5. It is the one that is liver specific. So they are elevated when there is damage. So these ones look at the integrity of the cell. So this is category 1. And this alanine aminotransferase formerly was called SGOT. No, this was GGT, what we called serum glutamate pyruvate transaminase. And this one was called serum glutamate oxaloacetate transaminase. Then this is lactate dehydrogenase. So these are the ones that test the integrity. Then category number 2, we shall see those that test synthetic function of the liver. Synthetic function, or those that test functionality of the liver. And those that detect the synthetic function of the liver, they include albumin. We see albumin being synthesized in the liver. We shall look at total proteins, and lastly we shall look at prothrombin. Time test. So these ones, we see prothrombin is detecting the presence of thrombin and fibrinogen, which are synthesized in the liver. So this one, they test the functionality. And wherever they become low, it means that there is a severe, or what we call chronic liver failure. Because for the hepatocytes to fail to synthesize albumin, meaning it is severe. Then lastly, the last category is the excretory function. These ones detect the excretory function, whereby they are looking at the integrity of the biliary system. They are looking at the biliary tract. And these ones include, we are going to look at enzymes like ALP. We shall look at enzymes like gamma glutamine transferase. This is alkaline phosphatase. Then we shall also look at enzyme like 5' nucleotidase. Then lastly, we shall look at bilirubin. And this bilirubin is divided into what we call, this is total bilirubin divided into indirect, what we call unconjugated, and direct, which is conjugated bilirubin. So these are the major tests that we can perform on the liver. So whenever they ask you in exam to outline any parameters or liver function tests, these are the one, whereby you have ALT, AST, LDH, albumin, total proteins, prothrombin, ALP, GGT, 5' nucleotidase, then bilirubin total and bilirubin direct and indirect. So these are the tests that we perform under liver function. And what is the significance? Why these tests? Why do people or why do doctors request to do LFTs? Significance of performing LFTs in the laboratory. And when do doctors request this? Whenever doctors have seen sign of jaundice, that is yellowing of the scleral membrane, especially the eyes, then a doctor sees someone who has come with ascites, that is swelling of the belly, and some people have edema, which is pitting. I told you some of the signs is pitting edema, whereby whenever someone has a swelling and you touch on it, the pit remains for long. That is what we call pitting edema. Then we have talked about ascites, yellowing of the, and even sometimes abdominal, what we call right abdominal pain. So you can always request these tests. And also, we are going to see that we are going to do them monitoring patients on some treatment. So significance number one of liver function tests is for diagnosis of liver diseases, which we covered in a video. If you haven't watched my video on liver diseases, please get time and watch about it, because that video I talked about all the liver diseases. So we are saying we can use LFTs to diagnose if someone has a liver disease. Another thing, we can use them to type liver diseases. You can use the word to type or to classify. You can use them to type liver diseases, or we can use them to classify to see is the cause hepatocellular, or is it hepatobiliary, or is it synthetic function, or it is excretory function. So they can be used to type or classify liver diseases. Another significance of performing liver tests, we can also do them to determine the severity, of liver diseases. As we are going to see that if I have results of liver function tests, I can use them to know, is this one really severe liver disease? Is it chronic? Is it acute? So we can diagnose liver disease, we can classify liver diseases, and still we can also determine the severity of the liver disease using liver function tests. And another significance that we can use these tests to monitor people, that is prognosis, monitor patients on treatment. Patients on treatment of drugs. Drugs like TB drugs like rifampicin, what we can call rifampin, people know antiretroviral therapy like zidovudin. So these are antiretroviral therapy drugs which have hepatotoxic effect. So whenever people on that treatment, we can always monitor them. So these are some of the major significances of performing liver function tests. And you always remember that these are not a standard one. Whenever you are interpreting liver function tests, always consider the clinical history of the patient. Consider also these tests, and together with the radiology, either the CT scan or the ultrasound scan, so that you can come up with a comprehensive differential diagnosis. And after knowing the significances, now we are going to look at tests and how can we interpret them whenever they are elevated. And we want to begin with enzymes which test the cellular integrity, that is majorly ALT and AST. So number one, I'm beginning with ALT, whereby this ALT we have said it was formerly known as serum glutamate pyruvate transaminase, and this enzyme is liver specific. It is liver specific. It is the one that is most liver specific. Why? Because it is exclusively produced by the hepatocytes of the liver. So it is liver specific compared to AST, which is known as SGOT. For AST, it is non-specific, non-liver specific. Why? Because for it is produced in other tissues. We're going to see ALT being produced in equal amounts in the liver and cardiac, that is the heart, but at the same time it is produced in skeletal muscles. Skeletal muscles, we can find it being produced in the kidney and spleen, and sometimes pancreas. So making it non-liver specific, whereas ALT, for it is specific. Why? It is majorly produced from the liver. So we can never interpret AST alone or ALT alone, but they are done equally. So we have always to interpret them together. And whenever I find when both ALT and AST are increased, we normally see them in hepatocellular damage, diseases that cause hepatocellular damage. And which are those diseases that causes hepatocellular damage? We see them in conditions of hepatocellular damage, majorly in hepatitis. And this hepatitis is majorly caused by, it can be viral viruses like hepatitis B and C. It can be toxins or drugs like paracetamol, like acetaminophen, or you can call it paracetamol drugs. Paracetamol causes much of the poisoning of the liver when taken in higher doses. Then we can also see autoimmune causes. These ones can lead to inflammation of the liver hepatocytes, and we find both ALT and AST is elevated. We said we can find these diseases elevated, that is ALT and AST, in hemochromatosis, which is an autosomal recessive disease, whereby it is due to accumulation of iron in the liver. We saw in ischemic liver disease, that is liver necrosis. This is due to blockage of the hepatocytes. Then we can also see them in Bardet-Chiari syndrome, which is the blockage of the hepatic portal vein. And we can see them in Wilson's disease. Wilson's disease due to accumulation of copper. It is also autosomal recessive. It is genetic. And also we can see them elevated in liver carcinoma. Liver carcinomas. So these are the diseases you can think of. And whenever you are suspecting viral infection, here you can order for a serology test on hepatitis B, surface antigen. You can also do hepatitis C to rule out the cause of this hepatitis. If it is toxins, you can do some toxicological tests to confirm. And if it is autoimmune, we can do some autoantibody detection to confirm if it is the cause of. Then if it is hemochromatosis, we can do even bone marrow examination to see presence of iron in the smear. Then if it is ischemic liver disease, we can always do what we call CT scan or ultrasound scan to see if the hepatic artery is blocked. Then, and even blood shearing, we can rule out that blockage of vessel vein occlusion of the hepatic part of vein. And if you are suspecting Wilson's disease, we can also always do a differential diagnosis whereby you can order for ceruloplasmin. I normally tell you for Wilson disease, we can confirm it with ceruloplasmin and write it here, ceruloplasmin. And whenever someone has Wilson's disease, we find reduced levels of ceruloplasmin. And for liver carcinomas, we can do alpha-fetoprotein. Alpha-fetoprotein can be a differential diagnosis of liver cancer, or what we are calling liver carcinomas. And after this, also doctors normally do what we call, a common done test is what we know as AST to ALT ratio. This is done whereby you get the results of AST and you divide them by ALT. For the differential diagnosis of alcoholic liver disease, that whenever you find the ALT to AST to ALT ratio is greater than 2, this confirms alcoholic liver disease. And when I do it, I find, so you can suspect alcoholic liver disease. We can see it in alcoholic liver cirrhosis still being elevated. So whenever I do AST to ALT ratio and I find it is greater than 2, I can suspect alcoholic liver disease. Even sometimes non-alcoholic liver cirrhosis can cause elevated ratio of AST to ALT ratio. And when I do the ALT to AST ratio, and I find it is less than 1, when it is less than 1, here I suspect hepatocellular damage. And this hepatocellular damage majorly, I can suspect viral hepatitis, acute viral hepatitis. I can suspect liver necrosis. Liver necrosis, that is ischemia, what we have called ischemic liver disease. You can also suspect toxins, or like even paracetamol poisoning. Paracetamol poisoning. So here we find AST to ALT ratio less than 1. That is how we can apply AST to ALT ratio for the differential diagnosis. And even this can be greater than 2 in the liver steatosis, what you call fatty liver disease. Fatty liver disease can also be high. And as I conclude with these two enzymes which are interpreted together, whenever I do ALT and AST, so when we do ALT and AST, and we find their results greater than 1,000, if they are greater than 1,000 international units per liter, this one confirms also it confirms viral hepatitis, acute viral hepatitis, acute viral hepatitis. It can confirm ischemia, liver ischemia, or ischemic liver disease, liver ischemia, or paracetamol poisoning. So in these conditions, we can find them whereby AST to ALT ratio is greater than 1,000. And I always remind you, please, always subscribe if you haven't subscribed. And always share your comments. Always share your comments so that we can always grow. So we have seen when the ALT to AST ratio is greater than 1,000, We can see it in viral hepatitis, in ischemia, even shock. Ischemia, this one is due to shock, due to blockage of the liver hepatic artery. And when we do, this is when it is severe. But when we do them, and we find they are moderately elevated, moderate, that is between 3,000 to 5,000, no, 300 to 500 international units per liter, we see this one in acute hepatobiliary damage. Acute hepatobiliary damage. And then when we continue and we do this ratio, we do the LFTs, that is ALT and AST, and we find the values are less than. When the ALT and AST values are less than 300 international units per liter, that is slightly elevated. When they are slightly elevated, like 2 times, 1 to 2 times, we find them in chronic hepatocellular damage, chronic hepatobiliary damage. We can find them in fatty liver disease, sometimes alcoholic liver cirrhosis, what we call liver cirrhosis. That is when it is slightly elevated. So as we are concluding this, we have seen we can use different parameters to come up with the differential diagnosis on near the cause of the disease, whereby you have seen greater than 1,000, that is acute viral infection, ischemic liver disease, and toxin or paracetamol poisoning. And then when it is moderately, you can see them in acute hepatobiliary damage, and sometimes liver cirrhosis, but we have seen it more in slight elevation of the AST and ALT. And that's why we normally say to confirm that someone has hepatitis or has a liver damage, the results should be at least 2 times higher than the upper limit. So this is what we can discuss about ALT and AST. We have seen the one which is liver specific is ALT. So sometimes we can always ask you that which other conditions can lead to elevated AST. AST can be elevated in myocardial infarction, in any muscle dystrophy, and kidney, and sometimes splenomegaly. So sometimes we do ALT. Note that we can do ALT to determine the cause of elevated AST or the origin of elevated aspartate aminotransferase. Because for AST, we know ALT is measured from the liver. So whenever we do the LFTs and we find ALT is normal and AST is high, we can suspect other conditions except the liver. That is muscle dystrophy, skeletal muscle dystrophy, myocardial infarction. We can see it in renal failure and splenomegaly. Sometimes the pancreatitis can be elevated. So we do ALT to ascertain the origin of elevated AST. That is a very big thing to note. Then the second one we are going to look at, after expounding more on ALT and AST, now we are going to go to the excretory function first before we go to synthetic. So we want to look at the excretory function tests, and those are majorly 5' nucleotidase. We want to look at GGT and ALP. So these are these guys are they measure what we call hepatobiliary diseases. The ones we have finished They are for hepatocellular diseases. These ones are for hepatobiliary. Any condition that affects the biliary tract, hepatobiliary diseases. So any condition that is going to affect this biliary system, from the biliocanaliculi to the right hepatic, left hepatic, then to the gallbladder, then into the common bile duct, and anything that blocks at the junction. So that is what we are calling hepatobiliary diseases. So we find among these three, 5' nucleotidase is the most specific. It is most specific for biliary tract. That whenever there is any sclerosing, these enzymes are produced from the epithelial lining of the biliary system. So anything that blocks, anything that affects the epithelial lining, because they are produced from the membranes. So anything that affects the epithelial lining of the biliary system or the biliary tree causes elevation of these three enzymes. But we are saying among the three, the one which is most biliary specific is 5' nucleotidase. Then followed by GGT, then ALP becomes number last. Why are we saying GGT is not more specific? For it can even be produced in organs like GGT. We find it in the kidney. We can find it in the intestine, in the pancreas. It can be produced from the prostate or seminal vesicle. So people with the prostate cancer, they can also find GGT elevated. And sometimes, so we have seen renal failure, pancreatitis, prostate cancer, sometimes metastatic cancers. Metastatic cancer. We see GGT is the first enzyme to be elevated in me. So whenever I ask you an objective, that which of the following enzyme is first elevated in metastatic cancer, that is GGT. Then we can see it also elevated in drug intoxication like barbiturates. Whenever someone is having convulsions and is on the barbiturates, and these barbiturates include the phenytoin and phenobarbital. Phenytoin, someone is on phenobarbital, phenobarbital, which is an anticonvulsant, and sometimes also people on anti-TB drugs like rifampin, what we call rifampicin. You find GGT, or what we call gamma glutamyl transferase, being elevated. So we are seeing there are many conditions that can lead to elevated GGT. And even not forgetting this one, let me put it in red, that is heavy drinkers, that is chronic alcoholism. So it is the first enzyme to be elevated in chronic alcoholism and metastatic cancer. So whenever you are taking alcohol regularly, we know that at one moment your GGT levels are going to be high. So that's why we say that they are not specific to hepatobiliary diseases. And what are hepatobiliary diseases? We can see they are both intrahepatic and extrahepatic. They can include cholestasis, primary sclerosing cholangitis. You can see those diseases like gallstones, or what we call cholelithiasis. We can see another disease whereby there is inflammation of the cystic duct, that is cholecystitis. Then cholestasis is the complete blockage. Then we see even pancreatitis affecting. We can also, so there are many causes, even cholangiocarcinomas. So we can see them elevated. Then ALT, what we call alkaline phosphatase, is also non-specific to the biliary system because it can be produced in tissues like placenta. To the pregnant mothers, we find ALP is elevated. It is produced in the bones, produced also in the kidneys. So So whenever someone is pregnant, that is in pregnancy, we find ALP is high, especially in the third trimester. Then bones, so any person with bone cancer, that is osteoblastic carcinoma, that is cancer of the bones, someone with Paget's disease, we find ALP being high. Even someone with renal failure, we find, apart from hepatobiliary diseases, also alkaline phosphatase is elevated in osteoblastic carcinoma, pregnancy, that is during second and third trimester, then in Paget's disease and renal failure, and not forgetting also in growing children. Growing children, why? Because their epiphyseal plate is open and their bones are growing. So actively growing bones also produce high levels of ALP. So apart from them being elevated or being for diagnosis of hepatobiliary diseases, we see ALP, what we call alkaline phosphatase, elevated in pregnancy, in the second and the third, in osteoblastic carcinoma because it's produced by the bones, in the Paget's disease, that is the disease of the bone, and also renal failure, and in growing children. So whenever it is always important to know the status of your patient before, ask them if it is a woman, are you pregnant? Or if it is a child, you have to know that they are also suspect to be high. So we can always do that. So after knowing these differences, and we have known that 5' nucleotidase is most specific for it, it is only produced by the hepatobiliary tree or the biliary system, so making it a very good marker for confirming the origin of elevated GGT and ALP. And that's why we cannot do this liver function test alone, because one can tell you where or the source of another elevation. So whenever I do tests and I find 5' nucleotidase is normal, and I find ALP is normal, and GGT is normal, no, GGT is high, I know what I can suspect. I can suspect these conditions like metastatic cancer, treatment on anticonvulsant drugs like phenytoin and phenobarbital, and also people on treatment of anti-TB drugs like rifampin. So you will always ask them, and also chronic alcoholism. And whenever I find 5' nucleotidase is normal, then GGT is also normal, and alkaline phosphatase is the only one which is high. Here I suspect it is osteoblastic carcinoma, pregnancy, Paget's disease, renal failure, and growing children. But if I find all of them elevated, 5' nucleotidase is high, ALP is high, and GGT is high, this one confirms hepatobiliary diseases, which we have always mentioned, like cholestasis, which is a complete blockage of the biliary system, then cholangitis, inflammation of the common bile duct, cholecystitis, that is inflammation of the cystic duct, then pancreatitis, and so many others can lead to both being elevated. So it is always better to interpret all of them not as a single but in situ. All of them must be considered when you are determining. But a point to note, don't forget that 5' nucleotidase is the most biliary damage specific. The way we saw in hepatocellular damage, ALT is more specific. Here we are saying 5' nucleotidase is most specific about the excretory function or the enzymes that detects the integrity of the biliary system or the excretory function. And whenever you find all these guys are elevated, we even expect bilirubin also to be high. Because why? We see even bilirubin also passes via the biliary system. So whenever there is any damage of the biliary system, even the bilirubin goes high. So that is what we can talk about. Another thing, after finishing these 3 5' nucleotidase, gamma glutamyl transferase, and ALP, we can talk about bilirubin. But before looking at the bilirubin, which is going to be number last, I can talk about albumin and total protein, but allow me to begin with bilirubin since it is following this. So bilirubin, and there is another video which I made about jaundice. If you haven't watched on it, you can always visit it to get more light on the bilirubin. And parameters on under bilirubin, you're going to find there majorly total bilirubin, then direct bilirubin, and indirect. And you do not need to buy the reagent of indirect. Why? Because we can always, whenever we have total bilirubin, indirect bilirubin is equal to total bilirubin minus direct bilirubin. So you can always use this formula to get the value, which is mostly asked by the pediatricians in the neonates whenever we are monitoring that transition of hemoglobin F to hemoglobin A, whereby these neonates, they always have higher jaundice, and we can always monitor them using this profile, what we call bilirubin profile, whereby you do both total bilirubin, direct and indirect bilirubin. And whenever you find total bilirubin is high, total bilirubin is as a result of hemolysis of red cells, and it is always characterized by jaundice, that is yellowing. So whenever you see yellowing, sometimes there is jaundice or sometimes there is no jaundice, depending on the severity. So total bilirubin being high and direct bilirubin being high and indirect being normal, this one, it always confirms us either hepatic jaundice, causes of hepatic jaundice, or post-hepatic. But whenever we do bilirubin total, we do bilirubin direct and indirect, and we find this one is elevated, this is normal, and this is elevated, we suspect conditions here like Crigler-Najjar syndrome, these are genetic disorders, and Gilbert's syndrome, whereby Crigler-Najjar is complete lack of glucuronosyl transferase enzyme, which conjugates bilirubin, and Gilbert, it is reduced levels of glucuronosyl transferase in the hepatocytes. And other causes can be prehepatic causes, can be also prehepatic, how like increased hemolysis we see in hemolytic disease of the newborn, like HDN, hemolytic disease of the newborn, and see it in sickle cell, anemia, in infections like malaria and typhoid, and other, and even blood transfusion incompatibility reactions. We can see it being. So this is what we can discuss about bilirubin. So here causes of this whereby direct is high but indirect is normal. We can see it in hepatitis, any cause of inflammation of the hepatocytes, can see them in Dubin-Johnson syndrome, can see them in Lotter syndrome, and any cause of the hepatobiliary. Any hepatobiliary obstruction can cause direct being high, whereas indirect is normal. And we have seen also prehepatic causes And then genetic causes like Krigler-Najjar, which is lack of glucuronoside to conjugate, and Gilbert's due to reduced, can lead it whereby bilirubin total is high and direct is high, but this one is normal. That is what we can discuss on the interpretation of bilirubin. For more information, we can visit my video on bilirubin to understand more about different types of jaundice and their causes. Lastly, I want to discuss with you protein and albumin, as we call it today. But before we go to protein and albumin, there is another test we can do, marrying ALT together with ALP. And that test is called the R value. R value, many doctors, many physicians like to do R value, whereby R value is equal to ALT divided by the upper normal limit of ALT, then you divide it by ALP divided by the upper lower normal limit of ALP. So this one gives you what we call R value. So doctors can use this R value, that whenever you find this R value is greater than 5, meaning ALT is higher, and this one is seen in viral hepatitis, or this is seen in hepatic pattern, hepatocellular pattern, anything that causes hepatocellular damage. And when you do R value, it is between 2 to 5. This one, it is mixed pattern, and R value less than 2 is seen in hepatobiliary obstruction. So this is the significance of R value. So doctors can use R value to determine which pattern. Is it hepatobiliary? Is it mixed pattern, both hepatobiliary and hepatocellular, or it is only hepatocellular pattern? Using R value, they can always determine that. So lastly, let us look at albumin and total protein. And this albumin, total protein, then albumin plus prothrombin time, these test the functionality, the synthetic function. They detect the functioning of the liver hepatocytes. So whenever there is, and we saw them that they can be elevated when there is severe hepatocellular damage. And these total protein and albumin, for them, whenever I do the test and I find total protein is high, I find total protein, they are low or decreased, and albumin, they are decreased. These ones are caused by conditions like severe liver disease, severe or chronic liver failure or liver disease. You can see them in malabsorption, and see them in malnutrition, because some of the proteins, we get them from the diet, which we can use also to synthesize albumin. And then we can see them in burns, severe burns. When someone is severely burnt, and we can also see them in parasitic infection. And lastly, we can see them in nephrotic syndrome. Nephrotic syndrome is whereby someone is losing proteins in urine. Someone with proteinuria, finding protein in urine, is what we call nephrotic syndrome. So all these conditions can lead to low albumin and low total protein. Reference range The reference range of this total protein, we saw it is 5.5, 6.5, or 6.3 to 8.5, or sometimes you can say 6.3 to 8.3 milligrams per deciliter, whereas albumin is 3.5 to 5.5 milligrams per deciliter. So whenever there is DRO, we can find them in these conditions. And they are rarely elevated elevation, whereby we find increased total protein and increased albumin. They are rarely seen. They can be seen majorly in dehydration, and sometimes hemoconcentration when you have over-tightened the tonic hemoconcentration. That during blood collection, you over-tighten the tonic during blood production or venous blood collection, you can find them elevated. But however, sometimes total protein alone without albumin can be increased in conditions like paraproteins, like multiple myelomas, which are always confounded with Benz-Jones protein and electrophoresis. You can find them in familial dysproteinemia, and we can also find them in inflammatory conditions, in inflammation, sometimes pregnancy, and do that. So these are other conditions we can find proteins elevated with normal albumin. So these are the things we can discuss about the interpretation of results. And whenever you are doing LFTs, you find the machine is giving you, it is telling you total protein is maybe 6.1 and it's telling you albumin is 6.5. Please do not sign off these results, because albumin is part of the total protein. So there is no way how total protein can be lower than the albumin, which is part of it. So whenever you're doing and you find albumin, the machine is giving you higher albumin than total protein, do not sign off those results. Always first look for the cause of that error. The same thing with bilirubin. Whenever you have total bilirubin, and total bilirubin, its reference range, we know that the bilirubin total is less. It should be less than 2.0 milligrams per deciliter. We know bilirubin direct should be less than 0.2 milligrams per deciliter. And for you do test in the lab, and the machine is giving you total bilirubin as 0.5 and is giving you direct bilirubin as 0.9, please do not sign off those results, because there is no way how direct bilirubin can be higher than total bilirubin, because direct bilirubin plus indirect you get total. So you cannot get direct bilirubin higher than the total. So never sign off. Before you sign out as a lab person, before signing out those results of LFTs, always make sure that the albumin is not higher than total protein and direct bilirubin is not higher than indirect. Whenever you find that situation, always troubleshoot your machine before giving out those results. So I end up by giving you the reference ranges of all results, and we are going to see that ALT, its reference range is 0, or some books give 5 to 45 international units per liter. Then AST is between 7, it can also be at 5 or even 0 is okay, to 35 international units per liter. Then GGT, or gamma glutamyl transferase, you can always see it from 0 to 55. international units per liter. Then alkaline phosphatase is always at 53 to 129 international units per liter. Then we have seen bilirubin total being should be less than 2.0 milligrams per deciliter. Bilirubin direct should be less than 0.2 milligrams per deciliter. Then total protein should always be between 6.3 to 8.3 milligrams per deciliter. Then lastly, albumin should always be between 3.5 to 5.5 milligrams per deciliter. So these are the reference ranges I want you to always master off your head. That whenever you ask these reference ranges, you know them off your head and you can easily use them to interpret liver function tests. Thank you so much for listening. Always remember to subscribe if you haven't subscribed. Share your comments so that we can continue learning more and more at Medical Sciences Made Easy by Naphtali Muhumuza. Thank you so much.